Hello, I'm Jan Leifman.
I'm Gayatri Pramal Menon.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Rohit Moudgil. Dr. Moudgil currently serves as the Director of Cardio-Oncology at the Cleveland Clinic.
In today's presentation, Dr. Moudgil discusses the association of cancer and cardiovascular diseases in conjoined twins.
Did you know that Dr. Moudgil is an international renowned researcher in cardiovascular complications of cancer therapy, heart failure, and inflammation of the heart? He also holds secondary appointments as a consultant scientist at the NASA Human Research Program at the Johnson Space Center in Texas. He's also a recipient of numerous awards, including recognition as a top Doctor of the Year award in cardiology.
He's truly an inspiration in the field of medicine.
So let's tune in and learn from this great global leader.
When we think of cancer and cardiovascular disease, they are very intertwined in a sense that effect on one of them actually cause implications on the other ones. And as the time goes on, it's becoming more and more relevant and apparent that cancer and cardiovascular disease are very, very interrelated to each other. We have made major strides in the treatment for cancer, and as the cancer survivorship is becoming more and more prominent, we are seeing much more of the cardiovascular disease. So it is quite apparent that there are two major diseases that causes death in our United States, and it is estimated about 18 million people are going to die with cardiovascular disease, and roughly 9 to 10 million people with cancer worldwide. They are quite interconnected to each other, and I hope with my presentation I'll show some of the things. So because of this intertwined nature, there's an emergence of this field. It's called cardio-oncology. And basically what the field talks about is this emerging field of cardiology, where majority of our patient population are comprised of patients who are afflicted with cardiovascular disease secondary to cancer therapy. So this is one aspect of the things. And I will talk in detail about that. And our goal of our cardio-oncology is to treat, learn, and prevent cardiovascular disease as a competing cause of morbidity and mortality in our oncological patient while safely administering life-saving cancer therapy. So although I'm going to be talking about the cancer and cardiology, cardiovascular disease as intertwined, but cardio-oncologists are the people who are cardiologists who are actually helping patients get over their cardiac problems so they can continue with their cancer therapy, or they have received the cancer therapy and develop cardiac diseases and help to manage them. And this is going to be clear and present danger in the coming year. So 50% of the people have cardiovascular disease, 33% of the people have cancer disease. And so if you do the ratios, about 28% of the patient population that you will see in your clinic and patients inpatient setting, 28% of them will have both diseases. And as the time is going on, so this is the graph looking at the cancer survivorship and the projected time of 2040, about 26.1 million people will be cancer survivor as the time goes on. And our hope is that, like, what we are doing is, while we are extending life of our cancer population, we are not flipping this curve to the heart diseases and making it more and more prominent for patients with the cancer survive to actually suffer from heart disease, and as a result, they meet their early demise. And we already know that there's this thing called a late effect in our cancer survivors. So when you look at the cancer survivors, what we have found is that after the cancer survivorship, and you look at the general US population, there's about loss of life expectancy of 10 years. So just by being a cancer diagnosis as well as getting treatment of it, they are hampered by the fact that there's a late effect and they're losing about 10 years of their life. And on top of that, if they have cardiovascular disease, this margin widens as the time goes on. So what is with the cardiovascular disease and cancer? So when you look at cardiovascular disease and cancer, what we see is this: there's a lot of risk factors that are actually common, whether you look at age, sex, genetics, tobacco, and a lot of the other things, diabetes, hypertension, dyslipidemia, which are commonly associated with cardiovascular disease, are also actually interrelated with the cancer. And the list goes on and as the time is going on, and we are finding more and more in this population. Oops. And this is the problem. Like, what happens with the cancer patients is that If they have cardiovascular disease, it remains untreated, and as a result, they develop more and more problems associated with it. So, for example, this is a graph taken from Mayo Clinic Proceeding by Al Kendi. And basically what they looked at the prevalence of cardiovascular disease and type of malignancy. So if you have hematological cancer, and it doesn't matter what kind of cardiovascular disease we're looking at, for example, coronary artery disease, cerebrovascular disease, carotid artery disease, heart failure, peripheral vascular disease, or any, about 33% of patients will have concomitant cardiovascular disease. The fraction is quite high if you're diagnosed with lung cancer, and about 43% of them will have concomitant cardiovascular disease. In breast cancer, the proportions are smaller at 17%. Colon cancer is 26%. Renal cell carcinoma is renal cancer is about 35%, and head and neck cancer is about 26%. So we already see that if you're diagnosed with cancer, there seems to be a proportion of the patients who already have a concomitant cardiovascular disease. And for different kind of oncological disease, there's different proportion of the cardiovascular disease. And they do affect each other quite a bit. So for example, this is a pictograph taken from the WHO. And what you look at is that 4.7% of the rate of heart attack or stroke are within 6 months of cancer diagnosis versus 2.2% participant who did not have cancer. So if you have cancer, your chance of getting diagnosed with heart attack or stroke is much, much higher. And this is just in the first 6%. There's 30% increase in death in lung cancer patient who has radiation shifted slightly towards the heart instead of the right side. So not only that, the treatment itself can increase the cardiovascular disease. We know that if you exercise, for example, if you do 5 hours of moderate exercise per week before your cancer diagnosis, your chance of cardiovascular disease is 40% lower likelihood of cardiovascular disease event in patients who exercise regularly. And I'm going to touch base on that one a little bit later on. We have a lot of patients right now that they got diagnosed with childhood cancer, for example, lymphoma, they got radiation, chemotherapy, and they got diagnosed at age 12. I'm seeing them in my clinic at age 40 with heart failures. So there is a real danger associated with it. Going on with that, 25% of the patients with endometrial cancer survivors are diagnosed with cardiovascular disease within 5 to 10 years. And that statistic is pretty staggering also, because patients are generally slightly younger when they get diagnosed with endometrial cancer. And 87% of the proportion of women with breast cancer tend to have at least one cardiovascular risk factor, whether it's a hypertension, obesity, or hypertension, obesity, or diabetes, as some of them. And 43% of the testicular survivor tend to have a high blood pressure compared to 31% who do not have any cancer. So as the time goes on, not only we are saying that if you diagnose the malignancy, there's more incidence of cardiovascular disease. If you have cardiovascular disease, they tend to portend more incidence of cancer also. So, and that is just about the cancer itself, but what about the treatment? So this is a really nice picture of, like, starting from 1920s all the way to the 2018, all the medications or chemotherapies and things have been developed over a period of time. And this has been correlated over here. So you can see that initial chemotherapy, for example, anthracycline, which was actually developed as an antibiotic, and turns out that it has an anti-tumor effect. It used to only cause cardiomyopathy, but not a whole lot. But as the time goes on, as we are developing more medication, for example, this is a targeted proteasome inhibitor, which can cause other things. For example, not only cardiomyopathy, but arterial vascular disease, as well as systemic hypertension. We're finding more and more neurochemotherapies, as well as immunomodulators. They're causing a lot more damage to the heart, all the way down to the CAR T-cell therapy, which is a new one. As you can see, a lot of different systems are affecting. And now the problem is this, that about 6 chemotherapies are being approved every 7 days from the FDA. And all they have to show is that if the quality of life has increased, a little bit of survivorship is increased in 6 months. And therefore, we do not have a long-term data for what happened to the cardiovascular disease. And most of the time, what we find is that that only happens when patients are getting the medication in real world. And we find these kind of problems in the real world, like seeing the patients in our clinics or inpatient service also. So as the time goes on, not only the cancer and the cardiovascular disease are intertwined, cancer can beget cardiovascular disease can beget cancer, and now the cancer treatment can also cause cardiovascular disease. So the question is like, okay, so if the cancer treatment causing cardiovascular disease, why not just hold the medication? This is a study published in 2013. And basically, this is looking at one of the medications, one of the therapies we use in breast cancer, and that's trastuzumab. So trastuzumab has been known to cause heart failure. In most part, it is reversible, and sometimes it's irreversible. So if you hold this medication only for 4 weeks, just for 4 weeks only, your chances of overall survival decreases by 15%. And that's a staggering statistics. That's only delay of trastuzumab for 4 weeks. And if you extend it further, and this was published in JAMA Oncology in 2020, and basically what they looked at was one group was called continuous therapy, which received about 108 doses of cumulative doses of trastuzumab, and interrupted, which got only 81 doses of. There was a staggering difference in terms of survival over 10 years of age. And when we look at just at the 6 years, about 56% more patients died in interrupted group rather than the continuous group. So again, showing that just stopping the medication is not the answer to the problem that we are facing right now. So coming back to it, so I showed you that the cancer begets cardiovascular disease begets cancer. There's a lot of factors that are intertwined with each other, like that makes cancer and cardiovascular disease a common enemy to us. And while we are doing much better in cancer therapy, what is happening is a lot of these patients are developing cardiovascular disease and flipping the curve, and they are dying from cardiovascular disease. So the question remains is how they are intertwined. What is the thing that is causing both of these two diseases to be interconnected to each other? So one of the ways they are interconnected is at the level of inflammation. So on your left-hand side, you'll see the innate and adaptive system in cardiac disease. So it doesn't matter what kind of cardiac disease you develop. So for example, if you have ischemic cardiomyopathy, toxic cardiomyopathy, peripartum cardiomyopathy, what happens is it results in immune activation, okay? So in an innate system, that can cause toll-like receptor activation. It can cause other kind of chemokines and inflammatory cytokines like IL-1, IL-6, IL-8, and TNF-alpha also. And what it does, it causes increase in inflammation. In the adaptive side, you have B cell and T cell. These get activated. For example, cytotoxic CD8 cell or helper CD4 cells, they get activated, and they can cause endothelial dysfunction, and that can result in eventual heart failure. When you look at the cancer, a similar mechanism is taking place. And case in point is that now one of the major therapies we use for cancer treatments, immune checkpoint inhibitors, and they basically rely on the fact that we have to activate the immune system in order to kill our own cancer cells. And in this case, for example, what happened is that there's a lymphoid cells that actually downregulate some of this inflammation that is targeting the cancer cells. As a result, the cancer can proliferate, and they can cause damage to the body. And what happens is that our body has homeostasis involved, in which the cells normally grow, and if there's inflammation, it gets regenerated, and that's the cycle happens. However, in certain situations, they escape this cycle and they develop into tumorigenesis and then causes cancer. So inflammation plays a very common role between two of these disease processes. And when we look at the cardiovascular disease, there's a big trial done by my good friend, Dr. Paul Ridker in Brigham and Women. And it was looking at IL-1 alpha inhibitor. And it showed that if you have increased inflammation, actually it decreases your mortality of cardiovascular disease. And statins were really, really helpful in that kind of setting. So we are already finding a lot of inflammation in cardiovascular disease, and it's already well established in the cancer world that the inflammation does play a major role. Beyond the immune system, there's other system also play in the role. So mainly, for example, this is looking at the hormones. So this is looking at the adipose tissue. So you're looking at the adipose tissue, and if it gets activated, a lot of other things that I mentioned previously, for example, TNF alpha, interleukin 1 beta, IL-6, they get activated. And if they get activated over a period of time, what happens is that there's some hormonal thing actually causes systemic inflammation, causing increased endothelial permeability, causing plaque development. It can decrease cholesterol metabolism and increase glucose production and insulin resistance, causing cardiovascular disease. And not only that, it can lead to diabetes, which is a major risk factor for cardiovascular disease. And when you switch to the right side of the screen, which is looking at the adipose tissue is very, very helpful in terms of causing distant metastases, and not only that, promotes the growth of the cancer cells. What happens with the decreased insulin sensitivity is that you actually produce things like ILG, insulin growth factors, which actually can cause increased proliferation and high invasion and high migration of these cancer cells. And that can result in increased cancer phenomena. So there's a lot of factors that are common between these two disease processes, so namely inflammation and at the hormonal level. And as the time going on, that we are finding more and more of these things. But the trouble is that once we start working with the cancer and cardiovascular disease, they can also cause formation of vicious cycle. So for example, what happened with the cancer cells is that when you have cancer, they're trying to promote the growth of blood vessels so that they can, the blood vessels can act as a conduit to have a distant metastases. And so what happened is that hypoxia-induced angiogenesis causes increase in hypoxia-inducing factor, VEGF, things like that. And we use TKI inhibitors or VEGF inhibitors to stop these kind of things. But these ones are actually cause cardiotoxicity. For example, a high rate of high blood pressure increase and other direct effect on myocardium causing heart failure. And when you have ischemia, there is a decreased VEGF, and that causes a stimulation of the VEGF, and that promotes tumor growth. So by intervening in the cancer itself, we might be inadvertently making the cancer growth happening more and more. So that is a real and present danger also. And we know that as the time goes on, a vicious cycle sets up where the treatment of the cancer or the cancer itself can cause cardiovascular disease, and the cardiovascular disease itself can promote cancer growth. So as I mentioned for the start of the talk, they are conjoined twins. They are connected to each other in various ways, either when you're looking at the shared risk factors, the clinical presentation also, various cardiac matrix that also provide the fodder for the cancer growth, the tumor stroma, the microenvironment, the angiogenesis, as I mentioned, inflammasome, all these things actually cause the formation of these two processes to be a conjoined twins. And we'll talk a little bit of the drugs itself, how they can help try to minimize this progression of the cycle, but that's where we are at right now. So this is more of a biology of the heart failure and the cancer, but it goes one step further. And when I say one step further, we have this thing called cognitive distraction. So when a patient gets diagnosed with cancer, what happens is that the treatment gets very focused on cancer itself, and all the other things takes the back seat. So for example, if the patient has a high blood pressure, it doesn't matter. A patient needs a cancer therapy right away, so they're getting the cancer therapy as it is, and so on and so forth. So a lot of things get missed during the diagnosis of the cancer and the treatment of the cancer. And for example, if they're feeling fatigue, which can be a symptom for cardiovascular disease, however, it is also chalked up to the fact that, oh, it's probably due to the cancer therapy or the treatment itself that is causing all these things. So there's a lot of things that can happen with cognitive distraction. And here's a gentleman who's looking at his cell phone who can fall in the abyss, in the canal, and just by the fact that we are concentrating on a small thing and not looking at the big picture around us. So, and this is quite evident, and we have found in the real life population also. So for example, when you look at the hematological patients, and if they have any kind of cardiovascular disease, only 51% of them are on antiplatelets, for example, aspirin. Only 47% of them are statin beta blockers. ACE inhibitor, and only 50% of them have a cardiology appointment. And that is not only limited to hematological cancers, but all across the board, we see the similar statistics in terms of only about 50% of them getting treated, and only 50% of them are seeing a cardiologist for their cardiovascular disease. So a lot of the things get missed. And what is the result of it? So this is a paper published in European Heart Journal in 2019. And basically, it looks at the risk of death from heart disease in the patients who got diagnosed with an oncological problem. So this is standardized mortality ratio for cancer. And basically what happens is that once the cancer treatment starts happening, there's a decrease in the rate of heart diseases in all of them. And the reason being is that because everybody is very vigilant when they're getting treatment. For example, if there's changes in ECG, they get referred to cardiologist, or the blood pressure is really going, patient had hypertension, now they are on tyrosine kinase inhibitor, and now the blood pressure is really going high, they get treated for that. But once they have survived the cancer, there has been no real management by the cardiologist, and they're often sent to their own PCP. And sometimes those things can get missed. And what we have found that over a period of time, and this 120 months, which is 10 years, we see increase in the heart diseases in all these other cancer and all sites also. So what we are seeing more and more now is that once they get diagnosed, there may be a transient decrease in heart disease, but over a period of time, we do see a lot of it. And this has been recognized by big authorities such as the European Society of Cardiology. So European Society of Cardiology is the first society that actually came out with the guidelines on cardio-oncology. And this is fresh off the press. This was just released 2 weeks ago in Barcelona, Spain. That's where the conference happened. And basically what they came up with is that there's a continuum, there's a dynamics of cardiovascular toxicity risk of patient with cancer over their therapy continuum. So when you look at the baseline and you see in the patients the baseline, no matter where they are, either they're high risk or low risk, our strategy is to try to decrease the baseline as further down as possible. So even if they are low risk, for example, their LDL is good, they are not diabetic. However, if they are not exercising, we should promote that they should exercise so that, you know, they are even at a lower risk than what they are at currently right now. And we know when they start the cancer treatment, no matter what, if they are in low risk or the high risk, right, the curves do go up high. And our job as a cardio-oncologist or any kind of healthcare provider is to decrease this curve as the time goes on. And when the cancer survivorship is going on, it becomes even more important to continue to decrease these curves as the time goes on. So this is the first figure in the European Society of Cardiology, indicating how important it is to recognize the cardiovascular risk factors in the patients who have cancer and try to decrease as much as possible so that they can live a cancer-free as well as cardiovascular-free life, okay? And in cardio-oncology care pathway, what we are saying is that there's a new cancer diagnosis and all the way to the long-term follow-up. First of all, have established a baseline of cardiovascular toxicity risk assessment, and then look at the low risk, moderate risk, and high risk. And if they're high risk, we have to follow them much more closely with the cardiology follow-up, as well as transthoracic echocardiogram every 1 to 3 years and every 5 years, and annual cardiovascular risk factor assessment. So for the low risk, you can go for 1 year assessment and just standard surveillance, and probably for moderate to severe. For high risk, a cardiology referral is warranted. And the thing is, at any time, if they have developing some kind of cardiovascular disease, cardiologist or other healthcare providers should be involved in their management. And thing is, so when you look at the baseline cardiovascular toxicity risk, there's a lot of things, and the whole process shouldn't involve the clinical assessment, looking at the cancer treatment history, cardiovascular history, the risk factor management, physical examination, vital signs, and we have to do this complementary test in order to figure out what are the baseline CV toxicity risk assessment checklist and find out what is the baseline risk factors are. No, sorry. And as the time goes on, we have to keep reassessing the risk So if they are the likelihood of the cancer therapy related cardiovascular toxicity, if they are low, we have to constantly look at it. If they are going from low to intermediate or high, and try to follow them as much as possible as the time goes on. And once we have looked at the baseline cardiovascular toxicity, we have to look at their cancer history, the cardiovascular disease, and we have to do all these testing and things so that we know where their risks are and to follow them appropriately as the time goes on and refer them appropriately when things happen. But unfortunately, what happens just in normal life, a lot of the times the primary prevention is missing. Patients get diagnosed with cancer, they get treatment for cancer, all they develop high blood pressure during the treatment and was prescribed, for example, some kind of antihypertensive, but there's no follow-up after that in terms of what's going on. So what happens is that because of the lack of the primary prevention, we have to do a lot of secondary prevention. But as I mentioned, since the cancer and cardiovascular disease are so intertwined, it is not now hard to believe that if we start treating patients with cardiovascular disease, we may garner some benefit from the cancer front also. And this is becoming more and more apparent as the time goes on, that we are seeing that with typical cardiovascular medications that we use on everyday basis actually has beneficial effect in the cancer world also. So let's start with the aspirin. So aspirin is one of the first medication that was approved for cardiovascular disease back in late 1980s. And right now it is used for all the cardiovascular diseases. For example, if you have coronary artery disease, if you have diabetes, and have hypertension, aspirin is being used. And the reason being is that no matter any kind of major coronary event, any stroke, any vascular disease, any vascular event, it is very, very cardioprotective as well as protective for the cardiovascular disease. But it's becoming more and more apparent that aspirin has much more bigger role to play just than in cardiovascular disease. This is looking at aspirin in various kind of cancers. And this was published in Lancet Oncology in 2012. And one of the things that it really pops out is that when you look at the colorectal cancer, aspirin seems to be very, very beneficial in these patients. And it turns out that aspirin not only has antiplatelet activity, but it does have some anti-metastatic activity, especially in the colon cancer. And we're finding more and more that if you're diagnosed with the colon cancer, aspirin has been very, very useful in these kind of settings. So, and thing is, this not only goes just at the time of diagnosis. So this is the data risk of colorectal cancer 10 to 14 years after randomization, patient who got aspirin and no aspirin. So patients who were on aspirin for cardiovascular diseases, and they looked at patients who were not on aspirin for any other reason. And when you look at them over 10 to 14 years and to see who developed colon cancer or not, the people who are on aspirin, which is blue line, tend to have lower colon cancer over 10 to 14 years than the patients who were not on aspirin. So it shows that not only aspirin is beneficial during the treatment of colon cancer, it can actually reduce your risk of developing colon cancer over a long period of time. And so the thing is, and this is looking at the rate of death from colon cancer, according to the frequency use of aspirin, after exclusion with selected illness. And selected illness is defined by cancer, heart disease, or stroke in this cohort. And what we find that people who are using more and more therapy or aspirin, their risk of death from the actual colon cancer is quite low. And this is significant across men and women, and it doesn't matter if they were, it's both in men and women. So this is a staggering result. So aspirin seems to be beneficial in not only preventing colon cancer, it might be beneficial during the treatment of colon cancer. And not only that, also the more you use the aspirin, the better it is for the colon cancer. So be mindful, these are like in preliminary data only, and there's more to be built up, but the use of aspirin in colon cancer has been well recognized. So what about the ACE inhibitors? So ACE inhibitors are used a lot in our cardiovascular diseases. So for example, it is used in stable atherosclerotic disease, post-myocardial infarction, patient with heart failure with reduced ejection fraction, and a little bit also preserved ejection fraction. They play a major role in prevention as well as management of cardiovascular disease in our arena. So when you look at what are the role of ACE inhibitors, in cancer population. So we already identified, and this is a very small picture. I don't know if it projects very well, but we have identified ACE enzymes as well as the angiotensin receptors type 1 and type 2 on various cancer patients. And thing is, it has turned out that the incidence of cancer is quite low if they get treated with ACE inhibitor rather than no ACE inhibitor. And it doesn't matter what how you manage the hypertension, but if you are an ACE inhibitor, there seems to be a decreased trend towards development of the cancer as the time goes on. And not only that, not only the incidence is kind of low with the ACE inhibitor and other antihypertensive, but the rate of death from fatal cancer is also low if you're on ACE inhibitors compared to not being an ACE inhibitor. So the ACE inhibitors seems to be also protective in this patient. And this is not hard to believe. We know with the ACE inhibitor is that one of the things angiotensin converting enzyme does, it increases your TNF alpha quite a bit. And we know this from the preclinical trials that the ACE inhibitor causes increase in TNF alpha. So as I mentioned before in our section of inflammation, so if you decrease the TNF alpha, that might be beneficial in prevention of the cancer. And right now we do use a lot of immunomodulator or immunotherapies, which actually reduces the TNF alpha. And this is a graph from published in European Heart Journal 2022. And basically it shows that the ACE inhibitor with the combination of beta blockers are very helpful in patients who have breast cancer and getting treated for both anthracycline and trastuzumab. The ejection fraction actually improved with the addition of both of them. So switching gears and looking at beta blockers. So beta blocker is a mainstay therapy for cardiovascular disease. So it doesn't matter if you have a high blood pressure, if you have a myocardial infarction, heart failure, beta blocker is a mainstay therapy for cardiovascular disease. So this is some of the data that was published in Cancer World. And Dr. Sood, who is in MD Anderson, does a lot of work with beta blockers and looking at the cancer itself. And this is just fascinating. So this was published in Nature Medicine. And basically this one looked at the tumor weight and the nodule itself. So if you increase the daily stress, it turns out that the tumor weight and number of nodules increases. And it doesn't matter which line of tumors you use. And thing is, if you use beta agonist, it again increases the tumor weight and nodules. But as soon as you start using the blockers, for example, propranolol over here, or you add propranolol to daily stress, it actually decreases the tumor size and number of nodules. And this has been shown in multiple cell population in the petri dish that the beta blocker is really, really helpful in these kind of setting. So preclinical model is very, very powerful in this setting. But not only that, we also find that with the breast cancer survivor, if you're on beta blocker, this is one of the study published in OncoTargets, the patients on beta blocker tend to survive much, much higher than the other patient. And the one on the right side is looking at the prostate cancers of patients who are on beta blocker. The percentage of them alive over a long period of time in months and 10 years is much, much higher in prostate cancer compared to the patients who are on other medications which were not on beta blockers. So it appears that not only in the preclinical model, but also in clinical model, the beta blocker is very, very helpful. But unfortunately, what happens is that once you find good thing in one thing, you start using for everything. So these are various clinical trials which was published on beta blockers, looking at like efficacy of beta blockers. But because it has been used for so many different cancers, and turns out that it may not be beneficial in all the cancer, and that's why it is not being currently used as an adjuvant therapy with a lot of the other cancer. But we believe, and we are doing active studies on it, that beta blocker in certain cancers is actually very, very beneficial. And we are looking at those specific cancers and see if we can incorporate or repurpose the beta blocker use in those cancer, because we know what happens with the adrenergic system is when the adrenergic system gets up, it's easier for the cancer to metastasize and localize in other places. So it's really, really cardioprotective in that sense, and not only that, protective for the cancer patient also. So the second last we are looking at is the statin. So statin has been used for primary prevention as well as secondary prevention in cardiovascular disease. And when you look at the statin use, we know this is in the prostate cancer mortality. Statin seems to be beneficial in the prostate cancer. Not the early form of prostate cancer seems to be benefiting from statins, not the prostate cancer, we tend to be late and aggressive. Statin doesn't seem to work in that kind of setting. And this is the statin risk of gastric cancer. Again, it is protective in that kind of setting. But one of the major places where it is really protective is the breast cancer, and especially the data on triple negative breast cancers of patients who are not ER positive, who are not ER2 positive. Those HER2 positive or ER and PR negative, um, they tend to garner a lot of benefit from statin. So I personally have a lot of patients who have triple negative breast cancer, and they are on statin because it's very, very helpful in protecting from cancer as well as the cardiovascular disease. And this is bringing up at the end of like the hub of the whole thing. So this is a paper that was published in Nature in 2020, November 2020. And basically what these investigators looked at was how PCSK9, which is actually a inhibitor we use a lot to decrease your cholesterol level, how it actually increases the immune checkpoint inhibitor potency. So PCSK9 is a receptor that is present on top of the cells. And it turns out that when this PCSK9 is activated, what it does is that um, when it is activated, it actually activates T cells also and cause a lot of activation of cytokines. What we have found is that, what they have found in this paper is that when you inhibit PCSK9 and give them immune checkpoint inhibitor, the actual activity increases quite a bit, and they respond much, much better. Clinically, since then, they have a lot of other authors have identified that if you have PCSK9 antibodies, the more antibodies you have in your serum, the better you actually respond to immune checkpoint inhibitors. And as you know, immune checkpoint inhibitors are currently being used for 50%, or roughly half of different kind of cancers out there. So that's really, really important. And the thing is, it's not only that, if they have a decreased PCSK9 receptor, they actually respond much, much better to immune checkpoint inhibitors. So it's becoming more and more and more apparent that these two entities are intertwined with each other. Last but not the least is the exercise. So exercise is a cornerstone of cardiovascular management. So for example, if you get the valve change in the cardiology, if you get bypass surgery, or if you even get a stent put in, or even if you're just coming with chest pain, which is unregulated with the medications, cardiac rehabilitation is a cornerstone of our therapy. And we know that because when you look at the exercise-based rehabilitation versus usual care hospitalization, the favor of the cardiac rehab is much, much higher. And this goes on for not only for the mortality, this is mortality, and this is hospitalization, this cardiovascular mortality. It is beneficial in both settings. And actually, what we are finding is that this is really, really beneficial in our cancer population also, to the point that in clinic, we are siphoning a lot of these cancer patients through our cardiac rehab and garnering benefit for them. So the problem is that, when we look at the patients in cancer, right now, what they happen, there's a heterogeneous population, and everybody's getting prescribed the same prescription. And as a result, the chance of non-responder is much higher than the responders. What we do in cardiology is that we look at the population and we divide the population based on like their characteristics. And based on that, we write the prescription. And that prescription is different for each and every individual. And what happens is our proportion of responders are much, much higher than the non-responders. So if we take our oncological patient, go through the same process of identifying the risk, identifying what are the things they require, writing the individual prescription for individual group, what do you find that we are getting a lot more benefit than your garden variety physical therapy. And the process goes like this. So ASCO cardiotoxicity guideline, patient receiving high dose of anthracycline, the standard exercise. So these are the things we are looking for. And if they have done CPAT, we can identify what are the things that is, and we're looking at the multi-dimensional data. If they have glucose intolerance or they're obese and things like that, then we do targeted dosing of these are the things we're looking to reduce. And if we do this targeted prescription, we find that they are doing much, much better in terms of the overall profile. so much so that there's a push for what's called core or cardio-oncology rehab, in which we are taking oncological patients, putting them to cardiac rehabilitation, and it is going very, very well. To the point that patients who have stem cell, bone marrow stem cell implantation, what we have been doing is taking those patients before the bone marrow stem cell implantation, putting them to cardiac rehabilitation, and midway they're getting the bone marrow transplant and putting them back on the cardiac rehab, and they fare much, much better in terms of reduced hospitalization and improved implantation of the bone marrow cells and then the other cohorts. So we are finding more and more of these things. So as the time goes on, it is very apparent that, you know, the exercise should be the part of the regimen. We push that for our cardiovascular patients, and we should have the same thing for our cancer patients also. So in the end, what I want to say is that all these things are interconnected, whether you have breast cancer or lung cancer or any kind of sarcoma or mandibular cancer, anything, all seems to be interconnected somehow. And all these things are leading to the heart one way or another. And that's what we have been finding through the research that we have been doing, as well as what we are finding in our patients. And so what the future holds is this. So once we identify this connection, I think the future is bright, because what we can do is, if we look at the history and learn the lessons from then, we can apply to the future, and that way the future will be bright. So the past is where you learn the lessons, and the future is where you apply. And hopefully we are doing that as the time goes on.